Continuing our discussion of pleural effusion, let us discuss empyema. Empyema means there is a pus in the pleural cavity. What could be the etiology? What could be the cause of infection of the pleural space? It could be because of the source could be from the neighboring structure, like in pneumonia, bronchitis, lung abscess, or a subphrenic abscess has ruptured, or a esophageal rupture, or there is a hemothorax which has been infected. Or the source of the infection could be from a distant source, like in bacteremia, or it could be an external source also, like penetrating chest injury or a chest tube placement or a thoracic surgery. Okay. Now, what are the common organisms? Pneumococcus, Streptococcus, Staphylococcus, Pseudomonas, Mycobacterium tuberculosis, Haemophilus influenza, as well as anaerobes. Now, what are the clinical feature? In aerobic bacterial infection, usually there is an acute onset of symptoms, while in case of immunocompromised elderly and an anaerobe infection, there is subacute presentation or chronic presentation. Systemic symptoms would be like high-grade fever, chills, rigors, malaise, weight loss. Respiratory symptoms would be like pleuritic chest pain, breathlessness, dry cough. If there is copious and purulent sputum production, that means there is bronchopleural fistula which has been created. Then examination we will have digital clubbing, chest wall edema, intercostal tenderness, and all the features of pleural effusion. On investigation of CBC, there will be polymorphonuclear leukocytosis, ESR will be raised, chest X-ray, similar finding, obliteration of costophrenic, costodiaphragmatic angles, air fluid level in dependent positions, LSS shaped, curved, CT scan, split pleura sign will be there, aspiration, you do the pleurosynthesis and then you'll examine the pleural fluid, cytology, the gram stain, acid fast specialized stain, glucose, LDH, etc. Then what are the complications of empyema? There is something known as empyema necessitans, where the pus dissect through the soft tissue and the skin of the chest wall. And there is a fistula which is created between the pleural cavity and the skin. This is known as empyema necessitans. Then it can rupture into the bronchus also, leading to bronchopleural fistula or pneumothorax. Pleural fibrosis could be the complication, and there is a hypothesis about it can lead to metastatic brain abscesses. Then treatment, depending if it is an acute, we will go for antibiotic based on the culture sensitivity, and also we will give a empirical coverage for anaerobes. Pus is drained in all the cases. Daily aspiration is done with a whiteboard needle. Also, we can try for tube drainage. If it fails, then we can go for thoracotomy or thoracoscopy. Also, we can go for intrapleural fibrinolysis. We can try if there is presence of multiple septies. Okay, in case of chronic resection is the ultimate treatment, we will go for thoracotomy with decortication. Decortication will strip off the whole of the grossly thickened visceral pleura, and the lung will re-expand and will obliterate the pleural space. Now, tubercular empyema. In tubercular empyema, the treatment will be ATT, repeated aspiration or tube drainage. Rarely we will need surgery. Now, let us see briefly tubercular empyema. It will have all the features of exudative pleural effusion. It can also have hemorrhagic pleural effusion. ADA level will be raised. ADA level will be raised. Then interferon gamma level will be raised. There will be positive PCR. Glucose level is equal to the serum level. Occasionally it goes less than 60. WBCs are raised. Small lymphocytes are seen. Then we can go for AFB stain or culture. Gene expert could be done. Then we can go for pleural biopsy, where they can have evidence of tuberculosis. And the treatment is generally ATT. Rarely we need surgery. So this is all about empyema. Thank you.